Everyone to this today's webinar live talk with Fund 101 on COVID-19. Thank you for taking time out today and being here. I'm Gianni de Munk and I'm your host. Today we welcome Jean-Daniel Chcihe, President of Fund 101 and full Professor of Intensive Care Medicine in Paris, Descartes University. We have also Benoît Misset, Head of the Intensive Care Departments of the University Hospital in Liège. We have Dominique Benoist, Head of the Intensive Care Department of the University Hospital in Gent. And we have also Professor Pierre-François Laterre, Head of the Medical Surgical Intensive Care Unit at Saint Luc Hospital, University in Brussels. And of course, our AXA Belgium CEO, Jef Van In. Just a little housekeeping before we get started. We'll be running a live Q&A at the end of this webinar. So don't hesitate. When you have a question, just pop them into the chat box of this webinar. For those who are just joining us, don't worry, there will be at the end a possibility on demand for a recording. So let's start, I would say. Dear Jef, only a few weeks after the lockdown, AXA launched a solidarity initiative for its employees to support and to strengthen 101 Fund. Please tell us more about it.
Well, so what an insurance company normally does, Gianni, is that we help clients who get into difficulties in an emergency. That can be due to a car accident, a motor accident, or a house which has burned down, or difficulties when traveling. This, of course, was something special and a unique situation, not only for our clients, but also for Belgian society, and I would say for the entire world. So we asked ourselves the question, what can we do? First thing we asked ourselves is, what can we do from out of our core competence? And so very quickly we decided to open our Doctors Online, which is for our employee benefit clients. They can receive free teleconsultations from a doctor. We opened that for all Belgians, whether they were clients of AXA or not. They could receive a free teleconsultation when they suspected to have caught COVID-19 and their regular doctor was not available for one reason or the other. So that was the first step we took very early on in the epidemic. But then we started reflecting, what can we do more, because we are an important stakeholder of this society. And so we decided to support Fund 101, which is a fantastic initiative which supports more than 1,200 intensive care units in over 60 countries. And so as AXA Belgium, we decided to make a donation of €100,000 to the fund, and also to mobilize our employees and broker network to make individual contributions. And we promised to double those individual contributions as AXA Belgium also. So as a result, we have had €12,500 in individual contributions, which we are going to double. So in total, we will be arriving at €125,000 to donate to Fund 101. But it's not over yet, so people can still make contributions. So I would put appeal to everybody to make a contribution to the Fund 101.
That's absolutely fantastic, Jef. What does AXA wants to achieve with this donation?
Well, we just want to do, Gianni, our part in this COVID-19 crisis, which I think every company, and you have seen that throughout the world, that everybody is affected by it. And so every company asks itself the question, what can we do as a company and as employees for a company, working for a company, to be a small part of the solution of combating this COVID-19 crisis worldwide.
Dear Professor Chcihe, I'm turning myself to you. Please tell us what AXA's donation means for Fund 101.
For us, it's a great contribution, and I'd like to start by thanking AXA Belgium for this very special effort. As you may know, AXA overall has entered into a partnership with Fund 101, and we've been very pleased to see AXA Belgium trying to mobilize its employees to increase the donations. And what we are going to do with this is to create a special fund, actually, in order to give everyone the possibility to contribute in Belgium with a proposal. So we will launch a call for proposals so that Belgian hospitals will be able to come up with ideas for a research project, either in clinical research, quality improvement, basic science, or things that are geared to improve the way we help patients and their families. And in one way, I would say this is a great opportunity to raise funds from Belgium for Belgium.
Mm-hmm. And dear Professor, what will the donations be used for exactly? So
as I just said, we are going to create a fund, and we will receive call for proposals starting mid-September. And a scientific committee composed by members of the scientific committee of 101 plus members of the Belgium intensive care communities, and we have 3 distinguished members of this community with us today. We will decide on the best proposals, and we will be able to come back by the end of the year with a selection of the awardees, and we'll be able to share with you exactly what will be done with this money. What we have to do today is to increase the contribution so that we can further increase our support to Belgium ICU community.
Thank you, Jean-Daniel. I'm giving you the opportunity to give the floor to your 3 close colleagues who are also participating to this webinar. So please go ahead.
Okay, so what I'd like to do to start with is to give you a brief summary of what has happened during this COVID-19 pandemic, so that we will then start to discuss with my esteemed colleagues and friends what type of response they have organized in Belgium. I told you very quickly about 101. It's a foundation that is really geared to advance intensive care. And by advancing intensive care, we mean trying to improve the way we treat patients by better implementation of what is already known, by providing ways to do better research, develop artificial intelligence algorithm, deep learning approach, and novel trial design, and fund initiatives to support patients and families. I realize that many of you did not even know that intensive care exists before the start of the COVID pandemics. And you did not know probably that actually it's a specialty that cares for you every time your life is in danger, and whatever the cause that will put your life in danger. And for us around this webinar, it means COVID-19. You know, this has been a great opportunity for us to show you what we do in our intensive care units. Many of you have seen this type of images all over the world. And it's really important to realize that this has changed the world everywhere. And that's well illustrated here by these covers of Time magazine. So started at the end of December, everyone felt, oh, it's going to stay in China. It did not stay in China. As you all know, we found a name for this new pandemic. It has become standard practice. We've sequenced the virus. We've done everything to understand the pathogenesis of this disease. We've understood how we transmit it from people to people, understood the importance of social distanciation, and understood what it does to the lung. And that's really one of the important things, that the severity of the lung disease put you in the intensive care unit and for a very long time. We've understood how it's spread from cell to cell, and there's nothing really very special about the biology of this virus and about how it spread. What's really, I would say, special is that it creates a very important inflammatory response in the lung, and that is going to trigger a very severe clinical picture that indeed will put patient in the intensive care unit for a very long time. Here you have a picture of what has actually happened, and this slide was created basically from data until June 20. And you can see that if you compare the UK, Spain, Italy, Germany, France, I would say almost even Belgium, the doubling time in the number of cases was roughly the same in all these countries. And you can see that these countries have reached a plateau today, and we may be able to discuss this. What's really interesting is that you see that in some countries that maybe have reacted even more slowly to the spread of the pandemics, we did not reach the plateau yet. And I would say it's quite interesting to see that in countries where they've taken this very seriously with adequate resources, and maybe with a tradition of social distanciation, such as in South Korea, despite a doubling time that was really the same to begin with. They reached a plateau, but the plateau was reached for a smaller number of cases. And it's worthwhile mentioning that in South Korea, they did test almost everyone. The last slide I would like to show you is this slide, where you can see that the number of deaths per million inhabitants is about 445 in France and 836 per million inhabitants in Belgium. That brings me to the question that I like to ask my colleagues in Belgium. How can they describe the system response to the COVID-19 threat in Belgium at the national, regional, local level in their hospitals? How did they actually manage with crisis management and in terms of treatment? So I'd like to hand you the floor. It's a great opportunity that we have to have with us three distinguished ICU physicians and three great friends. So over to you guys.
Who wants to start?
I can, if you want.
Yes, thank you, Professor.
So my name is Pierre-François Laterre, and as presented by Jean-Daniel, I'm the head of the ICU in Saint Luc University Hospital in Brussels. And what I'd like to share based on the question coming from Jean-Daniel is that, first of all, even though I've been working for 30 years in the ICU, we never met such a scenario in our entire experience. So at no time, even though we have yearly epidemics of flu, at no times we had to be facing such a scenario. So this was for all of us, and I guess for all hospitals and all ICUs, a unique experience in a sense that we had to organize our internal and entire system of providing care to people, how to organize the hospital or to organize the ICU, how to select patients for admission to the hospital and to the ICU, and how the teamwork has been organized. Because my other great experience from this crisis was that we did realize that we've been able to work as a team. And I think that's no actor within the hospital had not a part to play within the crisis. So suddenly, before the first patient was admitted to the ICU, we had organized the teams in the hospitals. We had to organize the interruption of the usual activities. We had to stop all surgical activity in the OR, and we started to build teams dedicated to the virus, both on the ward, the general ward, but also into the ICU, of course. And it was interesting to see how people did cope with the organization, and we had help also from other units, other departments to support the nurses' work, but also some proposal from physician, even though it was restricted to a critical care physician for the entire period. And so I don't know whether you can see my slides or not, because I cannot see them. Just to say that locally,
you can see them.
You can see them?
No.
No.
You have to share your screen.
I mean, it's not a drama. I can just tell the story without the support of slides. But so the institution is roughly 1,000 bed, and the ICU has 58 beds. We had roughly 420 patients admitted to the hospital during the period until now, and around 70 patients into the ICU. As said by Jean-Daniel, these patients do consume a huge amount of resource, and they stay for long. And we had patients staying for a couple of days, but in the vast majority, they stayed for more than 3 weeks, and we had patients staying till now more than 80 days within the ICU. The process and the work within the team was something that we had to create, discussing how to protect the staff, how to protect transmission, and at the same time, how to work in a systematic way, using the same procedure for all patients. It was funny at the end to realize that sometimes you were forgetting the name of the patient because they met roughly and they presented with the same scenario all the time. So it was not in like the usual days where you can attach a clinical picture to a patient. Here it was just the same clinical picture everywhere to all patients, and so sometimes even hard to remember exactly what they did compared to the other one. But at the end it worked, and I think that the survival rate was quite nice. And initially we were scared to have a large amount of patients dying on the ventilator based on the numbers provided by other countries or other ICUs. This was not the fact. I don't know whether it's because in the country here there is a kind of usual established practice of ICU, whether we'd be more lucky or not, but numbers achieved at the end were quite nice. And I think roughly this is it. I don't know if you have any question based on this, but I guess others will present their own ICU2 and their practice.
Yes, I propose that one of the colleagues, perhaps Dominique Benoist or Benoît Misset, can join him.
As you, okay.
Okay, I will share my slides. Do you hear me?
Yes, very well. Thank you.
So I'm Dominique Benoist, the head of department of the Gent University Hospital ICU. I will show you some slides about the ICU response to the COVID-19 pandemic here in Gent. So first, as you know, Gent is situated here, and the hotspot of the COVID infection was mainly Limburg and southern Wallonia. I want to show you these slides because we really had the time to prepare ourselves in contrast to this region. So there we really had an advantage. We knew 1 week before the arrival of the patients what we had to do. Now, what was known at that moment is that the status is not always known on hospital admission of these patients. So you need COVID cohorts and you need transit cohorts where you are waiting until the confirmation of the results. Other facts is that nearly 30 to 50% of these patients are admitted to the hospital. In Belgium, it's rather 20-30%. But we knew also that 10 to 20% would require mechanical ventilation, and about 10 days after developing the first symptoms. And unfortunately, it's mainly a frail older population and patients with underlying comorbidities having the higher risk of severe deterioration and mortality. So we decided early in the beginning of the pandemic to create an upfront buffer and triage zones to enable the ICU teams to focus on the most severely patients with chances of survival. Then, like it was already said, these patients really are seriously ill, in contrast to what we knew from China. I think that everybody suddenly knew that it was serious when we saw the pictures on television from Italy. Then suddenly everybody was shaken awake and knew that it would be a very serious infection. And so these patients require prolonged mechanical ventilation, often for more than 14 days. So we knew also that we had to concentrate the care in the safe existing ICU environment. And we decided here in our hospital not to extend outside the ICU. We had plans to do that, but only in what we call in case of war, where we were really overwhelmed, and then we would go, for instance, to the operating rooms. But this was not the case. We had the time to prepare, and we were never overwhelmed. And then another issue that we discussed a lot within our task force is that we also had to contain or to deserve a high quality of care to non-COVID patients, because we forgot them a little bit too much. We had to maintain an ICU capacity also for these patients. So how did we organize ourselves? We had an 18 beds COVID cohorts in the wards. We additionally extended the number of beds to 24 geriatric and palliative care beds for those who could not or who was not a good indication to go to the ICU. We also had even psychiatric COVID beds, because you have psychiatric patients with social behavior who can be dangerous and who had been cohorted also in these wards. Then we created a mid-care outside the ICU together with the pneumologist as a buffer zone. And then here you see we used a supplementary 6 beds in the ICU from the burn unit. So all these patients were transferred to Neder-over-Inbeek. And then we extended to 8 beds supplementary, even in the pediatric ICU for non-COVID patients. So in total, 60% of our ICU capacity was used for COVID patients, 40 for non-COVIDs, and in total we had 48 COVID ICU beds when we take into consideration the mid-care. So this enabled us to continue the care also in non-COVID patients. Here you see the evolution of the operating room activity during the COVID pandemic. This is the usually one of last year. So you can see that we have about 140 severe operations per day, with about 10 during the weekend. And here you see the beginning of the pandemic, where indeed also we had a lockdown of our operation room, but continue to have severe patients to be operated. And we had a 40% capacity in the operating room. So for instance, none of the patients with an oncological pathology were postponed surgery, because we were afraid to create also an excess in mortality there at the long term. Here at the middle of the pandemic, we accepted here 80. Well, we had in total 250 patients, but we had at the maximum 80 patients here in the hospital, with 40 in the cohort, 30 in the ICU, and continuously 10 patients approximately in the mid-care, so in the buffer zone. To give you an idea, and this is, I think, internationally, it's nearly the same. It's about patients were 62 years old. Most of them had comorbidities, but really minor comorbidities. That was at least the experience in Gent. So this makes us, I would say, susceptible, nearly all of us. And as Jean-Daniel already say, the length of stay was pretty long. It's 20 days, 22 days, and now it is ranging to 58. We have still one patient now who has more than 70 days in the ICU. This is here the mortality in Gent. So like Pierre-François and Jean-Daniel say, yes, we expected a very high mortality because we had numbers from China. So there was a little bit a huge ethical discussion how far we should go. But as you can see, and I think this is the case for the most university hospitals in Belgium, we achieved really a very good mortality with only 30% mortality in contrast to the expected much higher number of mortality. With 12% mortality in the ICU, despite these patients were severely ill, and once you are ventilated, we lost 9 patients on the 46. Then the human resources and safety, we wanted to keep the highly qualified clinicians in their environment, so we concentrated the care in the ICU, and we reduced the patients to nurse ratio. As you can see, we added nearly more than 10 nurses per shift, so we doubled the number of shifts. And in total, to give you an idea for those who are not working in a hospital, you had 104 clinicians per day who were taking care of the 36 COVID beds, which is huge, of course. This is pure ICU, this is not a mid-care. We alleviated also some specific tasks. For instance, the ICU personnel is doing the CPR in the hospital. We asked to the Department of Anesthesia to do this. Of course, we had a very high enthusiasm of the team, and it was a very good team spirit, despite it was very hard working. There was also a high confidence in the decision-making by the task force in the hospital. To give you an idea, we had only 34 clinicians who became COVID positive on the 6,500 workers, and you're considering only those who were working in the COVID area. We had none of them who became COVID positive. We had one outbreak in the rehabilitations where we had 3 clinicians who became COVID positive. And of course, we organized also psychological support by an experienced team. And of course, you had a lot of support and generosity of the society, restaurants, media. I think every intensivist weighs 3 to 4 kilos more after the COVID period than before, with pizza and so on, who came nearly every day. Then this is nearly my final slides. The well-being of patients and relatives. Well, we have a long tradition in Ghent to have an open, honest, and proactive communication with respect of patients' autonomy, of course, but within the limits of modern medicine. So we had the daily communication via phone, tablets, Skype. The visits were encouraged during crucial moments, and this was also in the beginning of the pandemic. So they were really encouraged. So patients who were referred from the mid-care to the ICU, we encouraged the relatives to come to see their relatives. Again, we had psychological support by an experienced team, not only for patients' relatives, but also for the team. And we organized systematic meeting with bereaved family after 6 weeks, but we do that usually also outside the COVID pandemic. Then we started now a step-down unit. So we had the mid-care. First, it was as a step up, where less severely ill patients were referred to the ICU when they became severely ill. And we used now that mid-care as a step-down, where COVID patients can be rehabilitated. And this is something normally that we should continue to do also in the coming months and years, maybe outside the COVID pandemic. And then we organized also a COVID follow-up. And I think many hospitals do this via polyclinics, seeing these patients at the long term. And this is my final slides. We knew, of course, also that in the nursing home, it was pretty hard to work there because of organizational issues and others. And so we outreached also nurses from different departments here in Ghent to help the nursing homes to tackle the pandemic and to try to control the pandemic. And I would like to thank all my team who was working for more than 60 days in pretty tough conditions. Thank you.
Thank you, Professor. I propose to give the floor now to Professor Benoît Misset.
Thank you. What we observed here in Liège was, in fact, exactly the same than in Brussels and Ghent, and I would say exactly the same than my 2 colleagues. I will try a little bit different, of course, but the picture was exactly the same. The first week of the first 2 weeks of March, we received 1 patient with acute respiratory failure due to COVID. At that time, we knew that we had to prepare just because we had heard from China, from Italy, and even from France. And so we decided to prepare and do all what Dominique and Pierre-François just said. Then, very rapidly, 1 or 2 weeks later, we received almost every day 5 patients with the same picture. Over 2 months, we received about 550 patients who were admitted to the hospital, and 105 who were admitted to the ICU. That is also for me, like for the other ones, the first time in my life that I received such kind of patients all in the same time at the same at this high rate. At the highest, at the time we had at the peak of the pandemic in Belgium, the peak of the activity in early April, 60 ICU beds were occupied with the COVID-19 patients, and 15 additional beds were occupied for all the other tasks that we have to do for non-COVID, that we had still to do to non-COVID patients, such as surgery. So 60 beds occupied with patients with acute respiratory failure and mostly with ventilators and mechanical ventilation. Like the other ones, we had to look for protections, as everybody heard in the TV. We needed masks. We were in shortage of masks, of different protections, of devices to ventilate the patients, of drugs, even of drugs and sedative drugs, and also even in nurses. The workload for our patients was very high, of course, and higher than usually, because at the same time we had 40 or 50 patients who presented the same disease with the same severity, with the same requirement in mechanical ventilation at the same time, while usually during the year I would say that we receive the same number of patients, but only 15 or 20% of them have really the same level of severity. The outcome of these patients was probably worse than in Gent, as I just heard. More than 30% of the patients died, and this high level of death is particular stress, psychological stress on the professionals who work in the ICU. Less than 30% recovered very early during the ICU stay, and about an additional third of patients are still recovering and are still undergoing rehabilitation and are still, in fact, in different hospitals just for rehabilitation. And we have still in the ICU, we have still 2 or 3 patients yet who are requiring very long-term mechanical ventilation and different intensive care. This is the picture of what we observe in all the area of Liège. We decided to survey all the patients of all the ICU of the western part of the eastern part of Wallonia, and you can see that among 250 patients who were admitted to ICUs and who were mechanically ventilated, you can see that almost 40% of them died after 40 days of intensive care, and that is a very high rate of death, and very similar to what we have heard from other countries. On the next slide. For that, I would say that we decided 3 main things in terms of investment and in terms of personal investment. We decided to hire 3 people. The first one was to hire a nurse to coordinate the follow-up after the ICU. just to make a link with what was just said by Dominique Benoist, we consider really that the most important thing to do now is to follow and to coordinate the course of the patients after the hospital or after the ICU, to coordinate different specialists and different paramedics that these patients require and will probably require for additional months or maybe years. The second person that we hired was a nurse directly dedicated to quality control within the unit, within the department. Just because it was evident that we had to have rapid responses to all the difficulties that we encountered. We could not wait for responses from the institution. We needed, for example, materials, masks, etc. We needed to have good compliance to procedure. We needed to implement new procedure, to adjust procedure almost every day or every 2 days, depending on what we learn from other countries, etc. And also we hired another research assistant just to perform more research and clinical research, because obviously there was a need for this crisis and also for the future, because all these people are really necessary to help run this kind of intensive care.
Thank you, Professor. Thank you, Professor. I think it's time now to go ahead and take some time for some questions now, because we already received a few questions. The first question I received is from a colleague of mine. What was your first reaction when you heard that the first COVID patient was identified in Belgium? Who takes the question? Who will take the question?
Well, I was taking my flight to Thailand at that moment. Simply to tell you how, in a certain sense, we didn't get all the information that I think this was also here in Gent, but and many of my colleagues, in a certain sense, we knew that the pandemic would come, but didn't take it very seriously because we didn't have really all the information that was required for that. Until then, you see indeed the reality, and it was a hard reality, but it was necessary, the reality on the television in Italy. So I was taking my flight to Thailand to go on holidays because we thought that it was flu, or a little bit more than flu, but not that serious. So 1 week later, I knew that it was very serious. And then I was, 4 days later, I came back to Belgium.
Okay. And it was very easy to come back from Asia towards Belgium at the time. Yes,
it was very easy. It was a little bit, how would I say? I would not say scary because I had a mask. But if you take indeed in the middle of the pandemic, you take a flight back to Europe. Everybody is looking to each other. 1 in 4 is caught. So it was, but I didn't get the COVID. So.
Okay, luckily. I go to the next question. According to a new international study by the Economist Intelligence Unit, Belgium's response to the coronavirus crisis has been deemed to the bottom of the class. What's your reaction to this conclusion? So propose one of the. If you want to join in, go ahead. Thank you.
You know, just before my Belgian colleagues answer this, I think that there's absolutely no country that can be proud of the response.
No, but I think you hear me.
Yes.
So I think there's a lot of discussion in the past, but also for the future. All we can say is that hospitals and ICU were ready before the first patient came. What was lacking is, and also the lockdown started very early. What was lacking is discussion on equipment, but most importantly, the diagnostic test. So that's why probably my explanation is that the country was exposed to a large amount of virus, and probably the amount of diagnosis is by far well underestimated. So we should look more at the number of patients admitted to hospital per millions of inhabitants, and then calculate the outcome. So it's quite easy to understand that we had a lot of deaths in the country. First of all, we counted all people in rehabilitation units as deaths from COVID, even though we got no demonstration. So where we should focus on is the number of patients hospitalized with a proven COVID infection, adjust for the population. And then we will realize that probably the country has been overexposed. We are the crossroads of multiple countries, you know. Everyone is crossing Belgium. And therefore, I think that the spread of the virus was much more pronounced than in Iceland or in Greece. So it was not a surprise somewhere. So I wouldn't discuss the quality of organization. What was lacking is material for protection at the beginning, outside the healthcare worker, or even for the healthcare worker, and diagnostic tests. Having more diagnostic tests, we would have increased the number of patients to be isolated, and we would have realized that probably the number of patients or people exposed to the virus was huge.
I have a question for our CEO, Jef. Jef, how did your life as a CEO change due to COVID-19?
Well, I think that's a very open-ended question. But so clearly we went with AXA already before the government decided to go on lockdown. We went, I think, 1 or 2 days prior to that. We went in full lockdown. For us, it was not a big move because everybody at AXA in Belgium is used at working 2 days per week at home. So all our processes and procedures were already, let's say, being executed at working from home. We're a paperless company, etc. Now, what I still miss most, and so we are coming back from lockdown only now. So I'm currently in the office, but people will come back end of June, 3 days for every 10 days. What I miss most is not, let's say, the regular day-to-day work, but most of everything which has to do with getting teams to be creative, etc. That is still very difficult to do that, everybody from out of his home space or home office. How did it change personally my life? Well, suddenly I found myself at home, I think like everybody, locked in, not being able to interact with people. There was lots of pressure, of course, like with any disaster or any, but we have been, over the past decades, we've had quite a few, not on the medical front, but we had the banking crisis, we had the oil crisis, we had quite some, let's say, things which put stress on AXA as an organization, but there we fared fairly well. So, touch wood, but I think as an organization, and hence me as a CEO of AXA, I think we did pretty much okay, given the circumstances which were unique in I would say, in modern history.
Thank you, Jef. I have another question for Professor Chcihe. How reliable are studies of the impact of blood group on the development of COVID-19 disease and the severity of symptoms?
I think that you have to take everything in the light of what Professor Laterre just said when he said that due to the lack of tests, no one has a clear idea of the real number of cases. So it's very difficult to look at these epidemiology studies. What we found, and I guess that my colleagues will agree to that, is that besides elderly patients at risk were sharing some, I would say, common risk factors such as hypertension, obesity, diabetes. And if you take those very common disease, I mean, I would say that roughly 80 to 90% of the patients that developed severe forms had these comorbidities and were elderly patients. So again, it's very difficult to make sense of these studies because no one actually knows how many cases we've seen in a given country because of the different strategies for testing. Strategies evolve over time in a given country. So it's, I don't know if my colleagues share the same views, but I believe we really don't know.
Thank you, Professor. I have a question for Professor Chcihe. Misset, excuse me. Summer holidays are coming up. Is it safe to travel by plane? And what about common pools, air conditioning in the hotels and rental houses?
So, is it safe to travel by plane? I would say that it is safe as long as you do not feel the plane. You do not sit just beside your neighbor, like in the train currently, and etc. etc. And as long as the company uses filters on the air conditioning system, because that works. But in fact, I guess that all the companies do that, or at least that is what I have read. Mm-hmm. It is safe to bath in pools. Is it safe? That's, in fact, in the pools usually you have chloride, and in the pools probably there are no viruses, or at least no virulent viruses. So it is safe. It is safe as long as you keep some distance from the other ones, like everywhere, and probably also as soon as the locker room is regularly cleaned. That's my response.
Thank you, Professor. I have a question for Professor Laterre. According to the figures available, what is the proportion of the asymptomatic people among infected people?
Yeah, this is also important to keep in mind that, as said previously, the lack of systematic testing may alter or modify the observed results. So the range goes from 25% up to 80% according to different studies. So probably the reality and the truth must lie in the middle. So at least probably one person out of two may carry the virus and be asymptomatic. So this is probably why the spread of the virus is quite easy, because people with no symptoms do carry the virus. And second, this supports also the need to have more tests to isolate people being positive, which was not possible and difficult even today, probably simply because of the lack of tests. But so the spread of the virus and the number of patients being asymptomatic is probably around 50%.
Thank you.
On having the virus.
Thank you. A question for Professor Benoist. Are the symptoms like loss of smell, impact on the lungs, are they reversible or permanent?
Well, this is probably a question coming from a wine drinker, I think. But no, so the loss of smell and taste is a classical sign. It's about 50 to 90% of the population developed it. Sometimes it is the initial sign, but usually it becomes okay after 7 days, 14 days, but is improved. I am not aware of patients, at least here, and not in the literature too, who had an irreversible loss of taste or smell.
Mm-hmm. Thank you. Professor Chcihe, according to you, what is the best strategy to adopt regarding the population testing?
That's a 100 million question. It depends upon your resources. I think that testing everyone and people that have actually no signs and no symptoms does not make real sense. We all agree that there's a possibility that you would be asymptomatic and be carrying the virus. The transmission from people that are asymptomatic is really lower. The risk of transmission is really lower. And then it depends upon which test you're using to test. If you're using serologic test, it just tells you that you've seen the virus. What do you do with the information? It's a good question. If you're using PCR, then you know that you're still carrying one way or another the virus, but it doesn't mean that you're contagious. And we know that people can have very, very, very long carriage of positive PCR. So what's really important is to be in a situation where when you have symptoms, you can be tested. So that indeed you can then be isolated, and based on epidemiologic status in a given country, you may decide that you are going to test people around this very patient. Today, for instance, this is what has been chosen in France, is to test only people with symptoms, and the decision is made by general practitioners.
Mm-hmm. Professor Misset, I have a double question for you. One, is there going to be a second wave, a new peak? And after developing the disease, are you immune to the virus? And if so, for how long?
So regarding the famous second wave, I would say yes, there will be additional cases. I believe that we are not we have not finished with this pandemic until we do not have a vaccine for all the world population. And when you see that what happens in China, for example, it is for me evident that we will still have a wave or waves. I don't know. I don't know the shape of the wave. Probably it will not be the same that the first one. The first one, no one was prepared, and we had not. And for the second one, or the so-called second one, for the future at least, it is also evident that we have changed our behaviors. So probably that will not be the same picture. Probably we will have to face a higher level of virus circulating among us, and probably also a lot of people with acquiring the disease and the severe disease. And the second point was, are you immune when you have been infected? So the response is yes, or at least probably yes. There is an immunity, but not all the people have the same immunity. There are what is difficult to observe is that there are mainly two systems concerning immunity: the systems with the antibodies that everybody knows, and this system, we can measure it. We can do serology, and we can know if you have if you produce antibodies. And there is another system which is mediated by cells, but by immune cells, what we call lymphocytes. And unfortunately, this is difficult to assess, at least in routine. That can be assessed only in research. So in fact, we cannot measure it. So we do not know exactly who is immune and how intense the immunity is. We do not know how long the immunity will last. Based on other coronaviruses that circulate usually in the years, we know that probably that can last for one individual for probably 1 year, probably not 2 years. Mm-hmm. So it's difficult to predict, but that there is something, but probably not perfect in terms of immunity.
I have an additional question for you, Professor Misset, coming from the audience. Were the investments enough for all patients you have received? Seems not, compared to all the patients, but it's a question specifically for you.
I would say yes. I would say that we were in the same situation that everybody in the Western countries. We had to look for different equipments and drugs, etc. But I believe that we were able to take care of all the patients. Mm-hmm. And I would say yes. I would say that the disease was very severe.
Thank you.
I don't believe there was a difference between the hospitals and the areas in Belgium in particular.
Mm-hmm. Thank you, Professor. I have one final question for Professor Laterre. Professor Laterre, according to you, what can we expect from vaccines once we find one? Is it going to be mandatory for people at risk only, or?
So to answer this first question, by definition, the expectation is to have a vaccine that is effective, that is efficacious against the disease itself. So there are a lot of research ongoing for the moment, and most are directed against a specific protein, a so-called spike protein of the virus. Some people are announcing that it should be ready by October, November. We don't know yet. What we don't know yet is the degree of protection. We know that based on other vaccines, not everyone will be protected, but at least providing a certain degree of protection. So this is the goal. Now, the other question is, should we restrict the vaccine to people at risk? This is not logical. I mean, we should protect everyone and give access to everyone so that we'll reduce the number of people carrying the virus, or at least developing some degree of infection and being the vector of additional transmission. If we had a limited number of vaccines, you would, of course, give this and provide this first to people at risk or elderly people. But in the logical of epidemiology, we should spread this to the entire population. You will probably not be forced, as you know, we are in a country of freedom, but at least it will be recommended, like we recommend vaccines for flu every year. So there's no reason not to provide this to everyone, even though you will not be forced. You know that some people are still reluctant to use vaccines because of their concerns of the risk and so on, which is probably not realistic. But we should give access to these vaccines to everyone.
Thank you, Professor. Thank you. It looks like we covered all our questions. It's still possible for the audience to send us questions, and we will answer them by email. Professor Chcihe, is there anything you wanted, something you wanted to share with us?
I think it's remarkable to see that the ICU community has been on the forefront and has organized itself with great collaborations and discussions. When we've heard that this was coming from China, there was actually there were discussions starting all over with our Italian colleagues, with our colleagues from Spain, everywhere, so that we could actually get prepared. And I would probably guess that my colleagues will agree that seeing what was going on in Italy has helped us to mount an efficient response. Then afterwards, we see that there are differences. There were differences in mortality despite mobilization of resources, and that tells us that there's still a long way ahead of us to make sure that we deliver intensive care in a very reliable and reproducible way, so that your fate actually does not depend on whether the ambulance takes a left turn and goes to one of the 3 centers we have in front of us, or to a center which is less organized. And this is what we are trying to tackle with our colleagues, and we'd like to thank AXA for helping us do that, actually. So again, a big thank you to AXA. It's still time to donate so that we can increase the number of grants that will be distributed to the Belgium ICU community, and I'd like to thank my colleagues.
Thank you, Professor. Before ending, I would like to give the final word to our CEO, Jef Van In.
So, well, yes, I think the conclusion is that everybody can do a lot combating the COVID-19 crisis, first and above all, by his or her own behavior, but also from out of his professional perspective. What we are doing with AXA, as an example, is that we are a very big player in preventing accidents at work. We insure, amongst other, a lot of hospitals also for accidents at work. But it is not only the physical aspect, it's also, like it was touched upon during the webinar, also the mental health. This COVID-19 crisis has put lots of pressure on employees, on private individuals, etc., due to the lockdown, due to the anxiety of getting ill, etc. And as an employer, we also need to be proactively dealing with that. So there we are going to look out to see how we can contribute to that. And then I just want to conclude that, yes, it's still time to make a donation. It will be spent very wisely on improving the capabilities of ICU units. And I would like to thank everybody. First of all, I would like, of course, I would like to thank the medical community and more specifically the ICU community, but also all employees of AXA and all brokers for having made significant contributions. And I'm looking forward to engaging with the Fund 101 in the future.
Thank you, Jef. And thank you, everyone. We appreciate you being here today. Please do not forget, I repeat, your message that it's still possible to contribute by posting a message with the hashtag AXA Solidarity Response on Twitter, Instagram, Facebook, and each post will unlock a €5 donation financed by AXA. If you want to become a superhero, it's your chance by helping Fund 101. So 101 needs you. I want to spell the correct website, so it's 1-o-1.eu for to donate. So that's very welcome. Together we can defeat this virus, and together we will save lives. Thanks for watching. Have a great day. Stay safe, and I hope we see each other next time. Thank you. Bye bye.
Thank you.
Thank
Bye
you.
bye.
Bye bye.
Bye.